welcome to OVA Hour. I'm Jennifer Garrison. I'm a faculty member here at the Buck Institute for Research on Aging. I'm also a member of the center here at Buck that studies female reproductive longevity. Buck has been pioneering a movement to advance the scientific research around female reproductive aging. And we've done this through a couple of mechanisms. One is that we have a center at Buck where we actually have scientists studying this problem. The other is through a global consortium. So it's called the GCRLE, the Global Consortium for Reproductive Longevity and Equality. And our goal really is to fund, collaborate, and stimulate innovation to try to better understand what causes female reproductive aging. We think about the end of fertility as setting off a cascade of health effects in a woman's body that can impact every aspect of her life. And despite the profound impact on health and well-being, female reproductive aging is really an understudied topic. So what we're doing is we're funding grants to scientists all over the world. We're building out a network of people who are interested in this area, including you as ambassadors for what we're doing. And our goal is really to build the field so that we can understand basic biological mechanisms that trigger female reproductive senescence. And we're trying to challenge the industry to rethink women's reproductive health and longevity, particularly right now at a time when these things are being debated in the larger public venue. So part of what I get to do that is so fun is, as I'm building out my network, is I get to talk to people every single day, amazing scientists, physicians, entrepreneurs, who are really working in this space. And OVA Hour is my opportunity to introduce you to them. So today I'm really excited to welcome Kara Goldman. She is Associate Professor of Obstetrics and Gynecology at Northwestern University. She's also a practicing reproductive endocrinologist. She's director of their fertility preservation program at Northwestern. She's also the Associate Director for the Fellowship in Reproductive Endocrinology, which means she's training the next generation of physicians who are going to work on this. Beyond that, she is also a physician scientist. So she has a lab where she also does research. She got her bachelor's degree at Duke University, her MD at Loyola University. She was an intern at the Washington University School of Medicine. Then she was a resident at Northwestern University, a fellow at NYU, and then she's come back to Northwestern University. Welcome, Kara. It's quite an amazing list of things that you're doing.
Well, thank you so much for the introduction, and thank you so much for having me, Jennifer.
Oh yeah, I'm so excited about this conversation. So I would really love to know a little bit more about your background and how you came into the field.
Absolutely. So I, entered medicine actually thinking that I would go into some realm of oncology and taking care of cancer patients. And then, really found my way to obstetrics and gynecology because of a passion for women's health. And within that field, identified this niche area of oncofertility, where we can identify women who are at risk of losing their fertility due to cancer and cancer treatment, and preserve fertility. And so it was really the clinical care and the science of oncofertility that I fell in love with. Went on to do my fellowship at NYU, and specifically, chose a program where there was a strong background in fertility preservation, where I could really kind of hone that interest. And through fellowship training, so OBGYN residency is 4 years, and then you go on to this subspecialty training, which is 3 years. Within that 3-year period of training, there's dedicated research time, and it was during that dedicated research time that I worked in the laboratory of Bob Schneider, who is an expert in mTOR, and I sought him out because of that expertise.
We'll come back to mTOR.
Yes, we'll come back to that. But really, I through my experience in fellowship and taking care of patients with infertility, and particularly patients who were facing infertility due to their cancer diagnosis and cancer treatment, it became abundantly clear that our options for fertility preservation are very limited. Mm-hmm. And, our options really consist of freezing eggs and freezing embryos. Mm-hmm. And we are very much lacking pharmacologic methods, so, medicines to preserve fertility during cancer treatment. So that's really where I decided I needed to focus my efforts in research. And that has really kind of been the basis for what I've done research-wise, and also, has built my foundation clinically as well.
Mhm. Amazing, amazing. I think a lot of people don't realize that IVF, in vitro fertilization, actually was developed specifically for oncofertility purposes, not necessarily to allow healthy women to have babies, but actually to help preserve fertility in cancer patients. Um,
Well, and the early IVF was really developed. The first IVF babies were, born because of women with tubal factor infertility, so trying to bypass the tubes and pursue IVF from that approach. But a lot of the kind of next generation treatments for that we're talking about, that are really kind of looking towards the future, things like ovarian tissue freezing, that is absolutely like that developed from this need in cancer patients. So absolutely, like they are part and parcel, kind of all the same thing. And so I think when I focused my area initially on taking care of cancer patients, and that continues to be a, tremendous part of what I do
mhm,
clinically, and a big passion of mine, it also becomes clear that, women are, facing infertility or loss of fertility because of their medical diagnoses, but all women will eventually face loss of their fertility and loss of ovarian function. And so this really affects every single person with ovaries.
mhm,
Um, and I think what's so important is, early on in my career, I was really focusing on the fertility side of things, and thinking about this impact of impaired fertility in cancer patients and women who lose their fertility. But the bigger picture that is, the elephant in the room that we need to be talking about, of course, is the hormonal function.
mhm.
And when we're looking at a patient with cancer who's going to preserve 10 or 15 eggs before cancer treatment, the reality is if they finish their treatment and go on to live a healthy life, they may not have any ovarian function. And the ovary, of course, is so much more than fertility. And so it became clear that this is a much, much larger problem than just preserving fertility. We really need ways to preserve ovarian function. And so that translates to not only the cancer population, of course, but the wider population of all people facing menopause.
Right, right. Yeah. Okay. So there's a lot to unpack here, and let's divide it and conquer. So, um, when we're talking about reproductive decline, like you just said, we can focus on the fertility aspect or the menopause aspect. So, um, just for those of you who haven't been keeping up with us, thinking about fertility, obviously ovarian decline, leads to all sorts of issues with fertility, including birth defects and changes in a woman's ability to have healthy offspring as she gets older. And then menopause, of course, is really when the ovaries run out of eggs. And people think about menopausal, I think, from the perspective um, of fertility, but actually ovaries are making a whole host of different reproductive hormones that are important for general health. And so when a woman goes through menopause, it changes her risk factors for things like stroke and cardiovascular disease, osteoporosis, cognitive decline, all sorts of things that are not related in any way, shape, or form to fertility. So let's start with the fertility side of things. We'll go in chronological order. So I'm curious to know when we talk about IVF, when we talk about egg freezing, you said there's only two things that you can help cancer patients with. One is egg freezing, the other is embryo freezing. So can you talk about each of those, and maybe also give us some insight into what the risks are, what the relative risk reward equation is that women want to think about when they're considering these options?
Absolutely. Yeah. So, the two, kind of well-studied approaches to fertility preservation, whether it be for a cancer patient or for anyone walking in the door knowing that they're delaying childbearing or are unpartnered and know they want to have gametes, which are eggs or embryos, frozen. So it's egg freezing or embryo freezing. Embryo freezing has a longer history. Egg freezing is relatively on the newer side, but is well studied, and at this point not experimental, and is clinically used very widely.
Mhm.
And really both involve the same processes. They involve a woman or a person with ovaries stimulating themselves with injectable medications, and so they're stimulating their ovaries basically to grow.
Mhm.
Now we know that in a typical menstrual cycle, a woman ovulates one egg. We have this kind of cohort of follicles that are the structures that contain eggs that are, ready to be stimulated by a hormone called follicle stimulating hormone. And in a typical menstrual cycle, only one follicle grows, one egg ovulates, but there is a pool of eggs that otherwise could be recruited, but undergoes cell death if they're not. And so what we're looking to do is stimulate the follicles in that pool to get more eggs retrieved in a given cycle. And so essentially it's a 2-week process. A woman uses injectable medications that are injected typically in the abdomen. And over the course of 2 weeks is in our office every couple of days for monitoring, ultrasounds, blood work to evaluate how the progress is going. We use medications to prevent ovulation. And then at the end of that period of time, we do a minor surgical procedure to retrieve the eggs. So this is done under anesthesia. It's an IV anesthetic. So a patient is asleep, comfortable, but still breathing on their own. We have a vaginal ultrasound probe with a needle that's attached, and that needle goes into the side of the vagina, into the ovary. We suction out the fluid and obtain those eggs. And then in the laboratory, this is where egg and embryo freezing differ.
Mhm.
So an egg,
So up until this point, everything is the same.
everything is the same. And this is exactly the same process for in vitro fertilization. So anyone
Mhm.
going through IVF for infertility, egg freezing, embryo freezing, this is all the same. We then in the laboratory, like this is where there's a large fork in the road and everything differs. If you're freezing eggs, we strip the cells off the outside of those eggs and freeze those eggs, and those eggs are forever going to have that quality of the 32-year-old or 35-year-old at the time that she froze that egg.
Mhm.
With yep, with
Oh,
embryo.
I just wanted to ask, yeah, so how many eggs does a woman typically, let's talk first about young women and start with the best case scenario. So, a woman does the stimulation, you retrieve the eggs. How many do you typically get?
So it depends on age, and most importantly, it depends on a woman's AMH level, anti-Mullerian
Mhm.
hormone. And so, some people may have, heard of this test in the context of at-home fertility tests, and there is a fair amount of direct-to-consumer marketing surrounding AMH right now. But essentially, AMH is a test that gives us an idea of how well someone's ovaries will respond to medications. So we can predict going in how many eggs, but on average, it may be somewhere between 10 and 20 eggs in someone who has an average ovarian reserve.
Okay, 10 and 20. And in young women, the quality of those eggs will be relatively high if they don't have any underlying dysfunction. As a woman gets older, it doesn't really, you can retrieve as many eggs as you want, but the overall quality has gone down, generally speaking. Okay, so you've got 10 to 20, you freeze them, and let's say you just freeze the eggs. Let's start there. What years, months, however long later, when you go to thaw them, what's the success rate for actually obtaining a viable pregnancy from one of those eggs?
Yeah, so we can kind of walk through numbers, and there is a significant amount of attrition from that frozen egg to a live birth. And so let's say we have a 35-year-old patient who froze 10 eggs.
Mhm.
When she comes back to use them, we know that about 80% of those will survive the thaw. So let's say we have 8 that survive the thaw, and then typically about 70 to 80% of those when we inject with sperm, and that's called ICSI, intracytoplasmic sperm injection. We inject them with sperm. About 70 to 80% will fertilize normally. So let's say we have something like 6 that fertilize normally. And then about a third will make it to the final blastocyst stage. And the blastocyst stage is the stage at which the embryo is ready to go back into the uterus or be tested for chromosomes. And we can talk about that in a few
Mhm.
minutes. Um, so she may only end up with, from 6
Two.
fertilized embryos to,
Mhm.
2 blastocysts. And in a 35-year-old, we know that only about 1 in every 3 embryos will be chromosomally normal, meaning 46XX or 46XY capable of producing a healthy live birth. And so the reality is The number of eggs we freeze has to be fairly high in order to overcome all of that attrition.
Mhm.
Even then, it is not a guarantee of live birth.
Not in any way, shape, or form. So the other thing I wanted to ask about, so for a healthy woman at age 35, you would have her go through multiple cycles to increase the number of eggs that she was able to freeze. Is that?
It depends on her ovarian reserve. If she's a 35-year-old who's able to freeze 25 mature eggs in one cycle, she may not have to repeat the cycle. And so much also depends on that patient's kind of anticipated trajectory. So I always talk to my patients about how, you know, we can freeze we can attempt a cycle now. We can touch base again in 6 months or a year and see where you are with your life, with relationships. And if it looks like it's going to be a long time, potentially before you start your family, maybe we consider doing this again. But it's tough because, this is expensive and it is time consuming and it is a tremendous burden on patients who are otherwise very busy with working and life.
Yeah.
And
I think a lot of women don't realize just how much is involved in getting up to the point where they can freeze their eggs, and how much it can interfere with your everyday life, with your with basically every aspect of your emotional and mental well-being. Can you talk a little bit about that?
Absolutely. Yeah. I think there's a lot of anticipatory fear leading up to it as well.
Mm,
Most patients at this point have, or many patients at this point have a friend who's gone through it and struggled, and maybe gained weight temporarily, and they
mhm,
worry about that, or they were worried because they, aren't sure that they're gonna be, emotionally able to handle it alongside their job, or one of the requirements really to keep patients safe during the process is to decrease exercise, and
mm,
decrease strenuous exercise. And so for so many people for whom that is important for mental health, telling them that they can't exercise for, 2 to 4 weeks is really tough.
mhm.
And then there are also, this is a medical procedure. And so there are risks involved, and we worry about things like ovarian hyperstimulation syndrome.
Can you talk about that a little bit? That was something that I hadn't heard of until a few years ago when I started reading about IVF.
Yeah, absolutely. So when we have someone who has a really excellent ovarian reserve, meaning their AMH is, above 3 or 4,
So
um,
typically a young person.
young person, or some of our patients who are more reproductively mature but have a really high AMH might be at risk as well. But certainly, yes, our younger patients with a high AMH are going to be at the highest risk of OHSS.
Mhm,
And this is a syndrome that is really unique to IVF and to this process. And it is kind of a constellation of symptoms that occur when the ovaries are stimulated, you have high estrogen levels, and then we use the hormone HCG to essentially mature the eggs and prepare for the retrieval process. And that hormone HCG, which is also the same as the pregnancy hormone, is going to basically stimulate this cascade where
mhm,
a patient will end up with fluid in her pelvis, potentially fluid in the lungs called pleural effusions, some electrolyte abnormalities. And so we have a lot of ways to mitigate this at this point. We use different medications besides HCG to mature the eggs. We use medications to prevent this. We try to avoid doing an embryo transfer in that same cycle. So we do a
mhm,
lot of freezing the embryos and using them at a later time rather than putting an embryo back so that we avoid HCG secretion in that same cycle. So there's a lot of ways to prevent it,
mhm,
but it doesn't eliminate it. And it is very uncomfortable. And so even in its most mild state, patients can be very bloated, very uncomfortable for days following their egg retrieval, and that can lead to, days off of work. And then the other risk associated with having enlarged ovaries is something called ovarian torsion, where the ovary can twist
mhm,
and its blood supply. And that's why we counsel patients to avoid exercise and, be really kind of cautious in those days surrounding their egg retrieval.
mhm. Yeah, that all makes sense. And there's also in a small number of people, there's a more acute thing that happens around hyperstimulation.
So that's the ovarian torsion where that
Okay.
ovary can twist, and it's very acute. It's a surgical emergency. It
Mhm,
requires laparoscopic surgery to untwist the ovary.
And it's painful, I've heard.
Very painful, very
Yeah,
painful. Happens in about 1 in 1,000 cases. So I think it's important to know that, we counsel every patient that these
of
things could
course.
happen. When you look at population data, the chances of things happening are quite low. But for an individual, it doesn't feel like 1 in 1,000 when it happens to you. And so I think every patient has to go into this knowing that, this is a medical procedure and it's not without risk, just like any other medical procedure involving a needle.
Yeah. Having said that, IVF is really, it is really the only option for a lot of women, and particularly, as you said, when you're trying to preserve fertility for women who go through cancer treatment, which obviously destroys their ovarian function. It's really their only option for having a biological child. So I'm always careful. I think I've been openly critical of IVF. It's no, it's not a secret, but I do always want to emphasize that it really is sometimes the only option that some women have, and so it's kind of amazing that it exists.
It is. And yes, I can't state this enough that it is an amazing tool. And, I think it's always, it's a decision people don't take lightly to, embark on egg freezing or IVF or embryo freezing or whatever it may be. And there's always some like, emotional complexity wrapped up into it. Patients with infertility don't want to be having to go through IVF. Patients who are going through cancer treatment, the last thing they want to do is another procedure prior to their
Right.
chemotherapy. But it is an incredible tool and, has resulted in, so many families that otherwise would not be in existence.
Having said that, though, you touched on this. It's important to point out that there is tremendous disparity in who has access to it. At least in the U.S., I think in other countries they've solved this problem, but here IVF is incredibly expensive, and especially if you have to go through multiple cycles, it becomes sometimes out of reach for people who don't have the financial um, basis for being able to afford it.
Yes, absolutely. And, it is remarkable to have had the experience of practicing in a state where there was no insurance coverage. So when I was practicing in New
Oh,
York City, it was before there was legislation passed for fertility coverage or, for IVF coverage specifically. And so patients were all paying out of pocket for IVF. And that meant that the population of patients we were able to take care of was very narrow. It was a lot of it was wealthy families who were able to afford it, or people who were, mortgaging their home to afford IVF. And then I moved from New York to Chicago, and Illinois had recently passed some pretty remarkable legislation for fertility preservation, but had for years had coverage for IVF. And so I went from New York, where patients were paying out of pocket, to Chicago, where my IVF patients, people who need IVF for infertility, have 4 cycles covered in a year for
oh
under
wow, that's a
yes,
huge difference.
a huge difference. And
But
so
it's like a patchwork, right? There's no legislation that covers everyone, and there's insurance companies are yeah, it really doesn't seem to be um, standard yet.
it is not standard, and it totally depends on what state you're in, which is, quite shocking. But, I'll have a patient who is employed, lives in Illinois, but is employed in Indiana or Wisconsin, but because their employer is based in a state where there isn't coverage, even though they live here, they don't have any coverage for IVF. So it truly depends on where your employer is based and whether or not your employer covers it. Fertility preservation is another story. There are very few states that have legislation to cover fertility preservation. And so this means that our cancer patients, thankfully in Illinois, have usually excellent coverage if they have employer-based coverage that's based in Illinois.
Mhm.
But there are only a number of states that have this. And so in most states in the US, if you have a cancer diagnosis and you need to freeze eggs or embryos, you are paying out of pocket or applying for grants. And so there are tremendous disparities. Illinois is the only state where Medicaid covers fertility preservation. So I am able to take care of patients here that would probably not be able to access care in most other states.
Wow, that's crazy. Yeah, one would think that Medicaid would be the same across all the states, but apparently not. Um, okay. So I guess before we move on to thinking about women who are maybe a little bit older, I just wanted to step back and just acknowledge that, well, I call it the anthem of IVF. This idea that IVF is a cure-all, that fertility preservation through egg freezing is going to be an insurance policy for young women, so that they don't have to think about it until they're much older. But the fact that women's ovaries start to decline in their late 20s and early 30s is something that most women don't think about until they really go to use them and find out that they're not working properly. So one of the things that one of the reasons that I've been critical of IVF is partly because it's been around for 45 years. Is that right at this point? 44,
Almost.
45, something like that. More than 40 years. And in terms of the research around IVF, I think there's been a lot of research that's been done to try to improve the procedures that are in place. The steps that are required to carry out IVF the way that it exists today. But I think it's a huge money making operation outside of academic centers like the one that you work in, and so there's not a lot of incentive for those businesses to try to put themselves out of business. And so there hasn't been a lot of basic research into trying to maybe find ways to make it so that we don't need IVF. And I find that to be incredibly frustrating. There's also a lot of misinformation out there, partly because these are for-profit businesses. They're maybe minimizing risk and maximizing sort of the potential for having a baby, and then compounded things like miracle babies and celebrities who talk a lot about IVF, fixing their lives. These things together, I think, make it a really complex field for women to navigate. So it's one of the reasons I really wanted to have you on.
Yes, and yes, there is a lot to unpack there, and I couldn't agree more with what you're saying. I mean, certainly IVF is an incredible tool, and so can't state that enough. You're right that we're in a tough position right now where there is a lot of kind of industry involved with IVF. We have academic medical centers where um, we have IVF programs and fellowship programs, but because of the direction the field is going, I do worry that we're going to have fewer and fewer people working on the basic science.
And why would that be? Just because of the disparity in the income possibilities?
Yes, that's a big part of it is, when you have someone who's been training for, 4 years of medical school and then 4 years of residency and 3 years of fellowship, at the end of the day, they're, ready to start working. And the idea of, taking a tremendous pay cut to work in an academic center and do research is less attractive,
Of
when they have
course.
a family support and so I think, and I think this is a problem, kind of in academia everywhere. And so, but I think the reality is, and then there's also, within our fellowship programs, we have dedicated research time. Some of that time, currently the requirement is 18 months, and, that's looking to shift a little bit more towards 12 months. I think in general, we're moving towards, less focus on, research, and just because of kind of all the complexities of research. And so I think you're right. But I think part of this is, if we look at, and certainly, when you mentioned that there's, hasn't been a tremendous change in IVF over time, it's true. I mean, when we look at success rates with IVF in women over 42, currently the live birth rates, according to SART, which is our national reporting kind of data center, where every IVF center who's affiliated with SART has to submit all of their data. So there's some kind of quality control across clinics. Over 42 years old, success rates are about 4 to 5%
Mm.
per egg retrieval, and about 13% in women 41 to 42 years old. And so the success rates are not really any different than they were 10 years ago when you look at SART data 10 years ago.
Mhm.
This really comes down to the quality of eggs. And so you mentioned this earlier that, you can have a huge quantity retrieved, but at the end of the day, it comes down to quality and the likelihood of that egg making a chromosomally normal embryo when exposed to sperm. And, so some of the advances in IVF have been focused on identifying that optimal embryo. So
Mhm.
pre-implantation genetic testing for aneuploidy, or PGT as people know it. Essentially that's biopsying the embryo at that stage when it otherwise is ready to be placed into the uterus. We can biopsy the embryo, find out which embryos are chromosomally normal, but we can't make chromosomally normal embryos if there aren't any healthy eggs to make them from. And
Mhm.
so in someone who's 42 and, may only get 5 to 10 eggs in a given IVF cycle, she may need to go through multiple cycles to identify that healthy embryo. And then that healthy embryo still only has about a 60 to 70% chance of live birth, depending on kind of where you're practicing. And so at the end of the day, we still need many cycles to kind of overcome all of um, the many inefficiencies with ovarian biology.
And of course, women in their 40s are the ones that have the highest rates of infertility and who might be the biggest population of non-cancer patients who are seeking IVF, which is unfortunate. Um,
Absolutely. Yes. And I can tell you, like, just every single day, and this goes to kind of your mention of misinformation and what people don't know about their fertility. The conversations I have on a daily basis are, why did nobody tell me? I had
right.
no idea this was going to happen. I had
Mhm.
no idea that my fertility would decline so significantly with age. There's a lot of focus, of course, appropriately so, on contraception and on preventing unintended pregnancies when we're adolescents, and we talk a lot about that. We don't really talk about you know, age-related fertility decline. And there's, I think, this false assumption that IVF is going to overcome any kind of infertility. And so I think maybe there is this kind of false comfort in, like, well, if I can't get pregnant, I'll just go to IVF. But then we end up with women who come in at 43 or 44, and it may be that they knew and they just hadn't found a partner. There's so many reasons. And so this isn't
Mhm.
necessarily just lack of knowledge. But the reality is this is women are having to use donor eggs, which may not be what they kind of had anticipated their journey to be, and it's a beautiful option for people who go down that path, but may not be what they anticipated they were going to do.
And more
um,
expensive.
and more expensive, and certainly not accessible to all. But then they look in magazines and they say, well, how did that celebrity have a baby at 50?
Mhm.
There's this assumption that that and not to kind of get into, of course, celebrities deserve their privacy, and I wouldn't want to make assumptions about how those babies were created, whether they were from donor eggs or eggs that had been frozen previously or embryos that had been frozen previously. But the reality is, if women aren't getting information from trusted sources about fertility decline, they may be going to sources that are presenting misinformation.
Right, and there's so much of it. But so I think IVF obviously can fill a very important practical gap. But this idea that IVF is the cure-all for this generation of women and women's health is really flawed. And we definitely are trying to change that narrative, which is why I'm talking to you. In terms of information, I agree. There's a huge lack of information out there. There's a lot of companies that are selling various things. You talked about AMH, direct-to-consumer tests, which are great. But a lot of times women will go searching for information about their health on the internet, click on a factoid, and then get taken to a site where they're trying to be, there's a company trying to sell them something. So one of the things we're trying to do through the consortium is build a knowledge hub, which would be a safe place, a trusted space for women and also physicians like you and scientists to come and get information about issues and topics around women's health and also around the research that's being done, that's been curated by scientists and doctors that has no agenda. It's just simply meant to be a rich source of information. So we're working on that right now, and hopefully we'll be able to roll that out soon. Um,
Going to be incredibly important. So,
yeah, and I'm going to need your help with that. Uh, I wanted to also, you mentioned something when we were talking about what we would chat about in this webinar, and you did mention that there is the silver lining, which is that when you talk to young women about IVF or about fertility preservation, sometimes they might find out sooner that they actually have a problem than they would otherwise. So that is a bit of a silver lining. It doesn't really make up for all the all the bad things, but it is something that people can keep in mind. And I would also say, you're exactly right when you mentioned that when we're young, we get so much information, and there's a lot of rich information around contraception, how to prevent pregnancy, which is obviously very important, especially in today's climate. But very little to no information about how a woman's body actually functions. When I ask most young women in their 20s if they can explain to me what their menstrual cycle is and what's actually happening inside their body during their menstrual cycle, nobody, not a single one of them. And I'm talking about scientists, not just anyone off the street. So there's a huge gap in our education system, and there's a huge gap just in the dialogue. So yeah, as much as we can improve that, I think it's a really important place to go.
I could not agree more. And, in counseling patients, I take care of patients from all walks of life who have all educational backgrounds. And across the board, like you said, there is a complete lack of knowledge about how someone's own ovaries and uterus function. And, this is even my physician patients who are not OBGYNs, have kind of specialized in other things, but these are physicians who went to medical school and they are shocked to learn about, ovarian aging and the function of the ovaries. And so you're absolutely right. There is a tremendous knowledge gap. And, what I think, and it's a little bit of a soapbox of mine, but there's this annual kind of women's preventive services initiative, where kind of guidelines are put out into OBGYN offices, and I'm sure everyone who's gone to an OBGYN has kind of seen these on the wall, and it's all the things that have to be talked about in a typical annual exam, and it includes lung cancer screening and lipid screening and all of the things that you'd expect to see in a primary care office, but there's no mention of fertility or reproductive aging, and and of course contraception is an important part of that conversation. But I would argue that understanding your own fertility and your own biological, your own ovarian aging is a critical part of the reproductive choice spectrum. So when we're talking about family planning and how to prevent a pregnancy, we should also be talking about how to make sure someone achieves their family building goals. And so I think there's just so much room for education.
Oh my God, 100%. I so agree. So we're going to work on that together. So the other question I wanted to ask you about IVF before we move on is just you study transgenerational safety. Can you talk about that a little bit and explain, why it's an important question to answer, and what you're finding?
Yeah, so I specifically study transgenerational safety in the context of mTOR inhibitors. And so we can go into that, when you want to transition that conversation. But you're right that everything we do has an impact on the next generation. And we don't think about that often enough. And so when we think about how, when we're going through IVF, our embryos spend their first few days in the laboratory. That has an impact potentially on epigenetics, which is kind of the way the embryo develops and what genes are turned on and off, and that kind of implications for the offspring and offspring down the road. And so everything we do, every medication we take, really is altering us in a way that it could be altering our our ovaries, and then therefore our eggs and the impact on the next generation.
Yeah. It's very cool stuff. So the elephant in the room, obviously, is that none of the treatments that we have for infertility are addressing the other functions of the ovary that decline with age. So once a woman's ovaries stop working, there are lots of downstream consequences, and those manifest in increased risk for things that I talked about earlier. There's the only way we have to mitigate those risks is through hormone replacement therapy, which is really an imperfect option, but it is really the only one that we have. So research around this area of science is really important, and I wanted to step back and hear a little bit about the work you do in your lab. And you mentioned mTOR. Maybe you could explain to us what mTOR is And I know you talk a little bit about a molecule called rapamycin, which many in the audience will probably have heard of, either with respect to immunosuppression during organ transplantation, or maybe more likely as a potential drug to influence aging.
Yes. So this is really, I really kind of entered this area again because, in my early days in this field, it became really clear there's no way to protect fertility medically during chemotherapy. And, the thought was we really need an agent, something like a pill or some kind of medication that a patient could take to protect the ovaries during chemotherapy because, IVF and egg freezing are so imperfect. And so, when we think about the part of the ovary that we really need to protect, there are multiple stages of follicle development, and follicles are the structures that contain all of the eggs. And most of our eggs live in primordial follicles, which are those really teeny tiny follicles that surround the edge of the ovary, and that contains all of our eggs. So we're born with about 1 million of those. We have about 300,000 at puberty and then about 1,000 at menopause. And that's the pool that, every month we ovulate one egg from the larger pool of follicles and lose about 1,000 more from this other pool. And during chemotherapy, there's a really rapid loss of egg cells from that other pool, from the primordial follicle pool. So the whole idea is, can we kind of preserve that pool and prevent activation from that small pool to the larger follicle pool?
And taking it further, just beyond the context of someone who's undergoing chemotherapy, in theory, if we were able to preserve that follicle pool, that could also potentially extend a woman's reproductive span, or give women who are in their 40s the opportunity to have more potentially higher quality eggs later in life, that would then both give them increased fertility, but also potentially push off the age of menopause and stave off some of those negative health consequences.
Yeah,
All
absolutely.
in theory. This is just one way we've thought about it, right?
Exactly. So, but it's really like that's the pool that we need to protect, both in the cancer population, but in all of us, because that's the pool that dwindles over time,
Right.
faster for some or faster for some than others. But so essentially, one of the factors that causes activation of that pool is something called mTOR. So mTOR is a kinase. So it is basically this protein that's a major metabolic regulator. It's involved in numerous signaling pathways, regulating mRNA translation, proliferation, cell survival. So it's basically a cell growth pathway. And it is implicated in a number of disease states. It's upregulated by nutrients, in some cases, upregulated by chemotherapy agents, by some growth factors, and it is interestingly upregulated in about 80% of human cancers. So it is a really important pathway, and we see that it's upregulated in a number of disease states and in aging tissues.
Mm-hmm.
And so the idea was, can we slow down that activation and preserve follicles in that early stage? And we know that there are a lot of drugs currently available that that are mTOR inhibitors, so that inhibit that exact pathway. So these are, the initial one was rapamycin. So that was the kind of the first mTOR inhibitor. mTOR was really first kind of identified in 1994, which was 30 years after rapamycin was actually identified. So rapamycin was identified in Easter Island. It was found to be really effective as an immunosuppressant and antifungal. And so it was used in those, kind of historically for those purposes, and continues to be used as an immunosuppressant, as a really effective one. But then it wasn't until 30 years later that mTOR was actually identified.
And just to interrupt, sorry, for people who haven't heard of any of this before, as an immunosuppressant, it's used during organ transplantation, right? So if you were to receive a new kidney or a new heart, you would take high doses of rapamycin to suppress your immune system to avoid organ rejection.
Yes, exactly. And yes, and it's still very widely used for that purpose.
And so what we're talking about is completely different.
Yes.
And also maybe different levels, different amounts of rapamycin. But so just very quickly, so that everyone can get on the same page as we are, mTOR signaling, as you alluded to, is really complex, and we're not going to dive into all those complexities today, but can you summarize just very briefly what it's important for in the ovary? Because it does a lot of things, right?
Yeah. So, yes. And so, just to kind of summarize all that, it is used in a number, there are mTOR inhibitors that are now used clinically in a number of different settings that are FDA approved, which is why we sought to use them as fertoprotectants. mTOR is important, yes, in a kind of in a number of ways. So primordial follicle activation, but also, it can influence, there's meiotic maturation that's involved in. When you inhibit mTOR in a mouse model, you can have reversible embryo diapause, so kind of the embryo stops dividing. It influences protein synthesis at the level of the endometrium, which is the lining of the uterus, can help proliferate, grow the cells that surround the egg cells in the ovary, so somatic cells, so kind of the other cells of the ovary. So it has a lot of functions in the ovary.
Hmm.
And so we have to think about that when we think about any treatment that we're using that, could manipulate not just the cell type that we're thinking about, but the other surrounding cell types. But so, and oh, sorry, Jennifer.
No, no, please continue.
I was
This is
just going to
fascinating.
So when we, initially used it, the idea was let's use it during chemotherapy and see if we can preserve those follicles in the mice. And so gave mice very toxic chemotherapy called cyclophosphamide. It's one of the most toxic to the ovary that's used, in most breast cancers. So kind of all reproductive age women who have cancer, many of them are going to be exposed to this very toxic agent that affects the ovary. And so we gave mice that chemotherapy agent alongside these mTOR inhibitors and ultimately saw that the mice that were treated with these drugs had preservation of primordial follicles and ultimately preservation of fertility compared to the mice that were treated with cyclophosphamide alone. But as kind of part of that, as often happens in science, something I wasn't looking for kind of popped up in that even of the controls, the ones that weren't treated with cyclophosphamide, but were just treated with, the mTOR inhibitor compared to those that weren't treated with anything at all, had many more primordial follicles. And
Hmm.
so it then kind of opened up this door that, really we should look at the longevity side of this as well. And so then treated mice in a similar way with those mTOR inhibitors at 8 weeks of age, so a reproductively young mouse, and then bred these mice from the age of 20 weeks until they were 11 months old. So continuously bred them to
And
see
11 months is pretty old for a mouse.
yeah, especially this particular strain. And so, a reproductively older, mature mouse. And over the course of that, that breeding cycle, we saw that there were twice as many litters and pups in the mice that were treated with the mTOR inhibitors compared to control. And so there was a really remarkable phenotype where clearly something is happening to these mice that are treated with mTOR inhibitors at the level of the ovary to yield kind of this phenotype, this kind of outcome. And so the next step really was, well, what about the offspring? If what is happening here? Why is it happening? And are the offspring healthy? And so I think what's important, in anything that we're doing that's going to potentially that focuses on the ovary is, what is going to be the health of those eggs that we're preserving,
Mhm.
and then what are those offspring going to be healthy and the offspring of the offspring, et cetera. And so we, looked at fertility outcomes in the offspring. We looked at health of the offspring, and we looked multiple generations down. So essentially, like the grandchildren of the mice that were treated. And we saw some findings that were interesting that we still are working to better understand. So some changes in size of the offspring. And so we have to think a little bit about like what is happening metabolically. We know that these drugs are very metabolically active. And so I think, as with anything, we just have to proceed cautiously. But it's, there's something there and it's
Mhm.
exciting. And certainly, these are drugs that are really promising in the aging community. And when we think about aging, how, we have to think about the ovary. And I know you
Mhm.
talk a lot about this, and I'm so glad that you do, because it's so critically important. But, if we can, think about prolonging the lifespan of the ovary, that could have major implications for improving health span and lifespan.
Absolutely, absolutely. And so, and the studies that you were talking about, were you using rapamycin or were you using a different mTOR inhibitor?
No, thank you for asking. I was
Mhm,
using everolimus, which is a newer generation mTORC1 inhibitor, and then
mhm,
also using a dual mTORC1 and 2 inhibitor called INC128 or MLN 128.
mhm. Yeah, so there's a lot of different potential chemicals that you could use, drugs that you could use to tweak mTOR signaling, and we don't yet know which ones really are the right ones, which ones are going to be, have the all the positive effects and hopefully minimize all of the negative consequences of messing with mTOR signaling. So that's really exciting, and I'm very excited to hear what happens next. Definitely, there are a lot of other, there's studies that are happening all over. Just a few that we know about in ovarian function. Yours is one of them. We funded a few grants to look at this in non-human primates. One of our grantees has gone off and is starting to look at really early stage clinical trials for rapamycin in females. But at the end of the day, rapamycin is probably not going to be the thing that people end up taking if this turns out to be a real a way to modulate ovarian reserve. Can you talk about some of the negative consequences of rapamycin treatment?
Yeah, I think that we would just have to think really carefully about dosing because, they are fairly toxic drugs when given in high doses. And so, in the cancer literature, and that's where really I based much of my dosing because I was focused initially on the cancer treatment groups. But in cancer trials, a lot of patients have GI side effects, something called stomatitis, so kind of ulcerations of the mouth,
Mhm,
and many are facing side effects that are so severe that they discontinue and kind of disenroll from their trials.
mhm.
And so, again, those are high doses used in cancer treatment. And so I think this is where, tailoring dosages is going to be really important and looking really carefully early on for side effects and, essentially identifying a dose that would be effective enough from the fertility standpoint, but without those toxicities because they are challenging drugs to take.
Right, right, right. Yeah. Oh, this is so fascinating. Unfortunately, we're running out of time. So, is there anything else that you wanted to tell me or to tell the people who are watching about what you're doing, or anything you want them to know?
No, just that, I think this is just a really exciting time to be in reproductive medicine. And, at the end of the day, it's all about our patients and making sure that we're doing the right things for our patients and giving them all of the options that we can and continuing to ask hard questions so that we can make the care better for our patients.
Yeah, I am so appreciative of you and your work, and I'm really excited to hear what happens next. And maybe, if you're willing, we'll have you back on at a later time to talk more about the things that we didn't touch on, things like HRT and what happens after menopause. But thank you so much for your time, and thank you to everyone who tuned in. And please visit our website at gcrle.org if you want to learn more, if you want to get involved. We're always looking for ambassadors to spread the word about what we're doing. And thank you.
Thank you so much for having me and thank you for the incredible work that you're doing, Jennifer.
Yeah. Okay. Bye, Kara.